Hi, I'm,
Thank you
I'm
so
Dr. Dufresne. I'm a craniofacial surgeon. I'm here with Michaela Poling, who's our research assistant. Today, we're going to sort of discuss the better understanding of Freeman-Burian syndrome, go through the barriers, experiences, the outcomes, and efforts to really define the standard of care.
Thank you for
We have nothing to
joining.
disclose. Um, We have had contributions from many surgeons and physicians of multiple specialties that help to contribute to this discussion and the recommendations. What we're trying to learn today is areas where there's been disagreement, misinformation, or misunderstanding about the Freeman-Burian syndrome. Um, because it is rather rare and there's been some confusion of the diagnostic and contributory findings, we want to try to explain the medical, surgical, aesthetic, and psychosocial challenge that many of these patients experience and try to improve and justify the care and the outcomes for these patients. Now, I'm going to introduce Michaela now to further discuss some of these things, and I'll come back at the end.
Hello, thank you for having us. We appreciate Genetic Alliance inviting us to give this webinar. So first of all, we need to talk about what our goals were really and what the problems are in the literature, the knowledge gaps that we were trying to address. So there's widespread disagreement, some misinformation in the literature, even after some good genetic work has come out, and this misinformation and misunderstanding seems to be the norm. Just looking at a few areas, there are more than 6 different names used for this syndrome. There are 6 different types of conditions it's said to be everything from a basically a limb disorder problem, an arthrogryposis, to a skeletal dysplasia, a musculoskeletal disorder, a myopathy, and a craniofacial syndrome. And there doesn't really seem to be much agreement rather on any of those. Who discovered it? Uh, it's widely said that Freeman and Sheldon first described the syndrome, but new evidence suggests that Freeman did and Sheldon described something that's now known as Sheldon-Hall syndrome, which is similar in appearance but reacts very differently when you try to treat it and is a more mild condition overall. Inheritance is now widely known to be an autosomal dominant condition, but this isn't widely disseminated in the literature in the way that it ought to be. There seems to still be some disagreement. What's the prevalence? It's an extremely rare condition, so understanding the prevalence can be tricky, but there was a study done in, I believe, 1985 in the UK that lumped the syndrome in with some skeletal dysplasias, and they came up with a figure of 1.1 million, 1 to 1 million ratio. And that has stuck and it's been repeated. Referral. Who do these patients primarily need to be treated by? The de facto referral has been genetics, but then again, geneticists, as predicted by the late Victor McCusick, now have become generalists. So what was really a very niche specialty now may not be the most appropriate place to send a patient who clearly has a specific type of problem. Maybe we should send that patient to someone who deals with those specific types of issues and kind of put the genetics to the side since you're not to the point of treating genes yet. We're treating patients. As you might imagine, this is leading to a very chaotic situation for patients, for families, and that doesn't lead to very good outcomes. So we're trying to address this. But there are many barriers to doing research in this area. You have a very small number of people throughout the world. So first of all, you have different languages, different beliefs, different customs, different ideas about what a congenital condition, congenital meaning present before birth or at birth, different ideas about that. So that's one thing. But then the barrier of doing research has been raised by prior researchers who left patients feeling used, and that's not good. Also, funding. The applicability of research in this area doesn't have a whole lot of outgrowth to other types of problems. I tend to think that it may, but it's not a very clear-cut issue, so the funding just isn't there. In our particular case, we had very, very small private donors, very small, and we had one church dinner. That was it. So there's no institutional interest. There's really no collaborative interests. Patients really haven't wanted to participate. We've had 3 studies open for a number of years, and we've had very, very little interest, and no one's actually completed any study. There are only 2 prior studies that have been published actually about the syndrome. So then trying to do basically secondary research and look at data that is already in existence and try to analyze that data, that doesn't really work. With only 2 studies of very low caliber as far as what you would consider for any type of rigorous methodology. Almost all studies are case reports, published papers rather. So that's an interesting point. If all of the published articles, or almost all of them, are case reports, then those are all patients. Maybe we could do something with that. And we did. So without the ability to involve new patients in a traditional clinical research sense, or without the ability to do a meta-analysis of other studies, a meta-analysis taking numbers from other studies and putting them together and reanalyzing them, are you there?
Yes, we can hear you.
Okay, all right. My screen changed and I didn't know. So we put the cases together, we aggregated them, and we analyzed those. This was the only feasible option, and it has helped us to bridge this gap. It's not perfect, but we included all patients published in the literature who had a stated diagnosis of Freeman-Burian syndrome. And we'll go to the next slide. So our aims were to resolve these disagreements that we've discussed and hopefully then take something from that that we could use to generate some basic recommendations to improve the standard of care. So we were able to do 2 systematic reviews. We were able to do a meta-analysis using the case reports that were published. We put those together and made basically a mini study of those. So that was helpful to get individual information about people and to see primarily, is this being diagnosed accurately, and making a clinical judgment call on that. Also, we did another systematic review on psychosocial concerns, but because so few of the case reports included some mention of psychosocial status, then we needed to include other types of craniofacial conditions that had some similarities to the syndrome. And we did that. Most of the exclusions were for a lack of relevance to the syndrome, lack of availability, or they were in a language that we didn't have the ability to translate in-house. So this is really interesting. Only 80 of the patients met the standard accepted criteria that was published in 2006 by Stevenson and colleagues. That's out of all of the cases that have been published. And we had multiple contributors reviewing these cases, so there was agreement in this. There were at least 2 clinicians who reviewed every case. However, there was an additional 39 that met one of the diagnostic categories that we developed based on the original criteria. The original criteria is remarkable in that the only part of it that they identified that made the diagnosis were the craniofacial findings, the face and the skull findings. So we decided, if that's what makes the diagnosis, let's build some additional diagnostic classes based exclusively around that. Let's have one that includes only craniofacial findings. Let's have another that includes craniofacial findings and upper extremity, hands, arms, or lower extremity findings, but not both. The original criteria requires 2 different areas of arthrogryphotic findings, or contractures, malformations, basically, in addition to the craniofacial findings. However, they articulated that it was the craniofacial findings that made the diagnosis. So why include anything else as a condition? There were no significant differences between the 80 that met the standard criteria and the 39 that met one of our criteria. So I've kind of already gone over some of this, and here it is just to reiterate. Importantly, no one was missing a Freeman-Burian diagnosis. So all of the patients who had a Freeman-Burian diagnosis were identified as that, but not all of the patients identified as a Freeman-Burian diagnosis did, in our review, was that confirmed. However, we did look at some other syndromes that are similar, and we did not end up reclassifying those as Freeman-Burian syndrome. And as I said initially in beginning, who do we send these patients to? Do we send them to genetics, or do we send them to someone that's more specific to what their problems are? And if their problems are primarily craniofacial, who has the best training for that? Probably it's going to be a craniofacial surgeon, and hopefully one who has additional training in a craniofacial fellowship. And that's what we found. We found that plastic surgeons had the greatest diagnostic accuracy, and orthopedic surgeons, who primarily treat limb malformations, they had the lowest accuracy. There were only 5 descriptions in the case reports of patients' psychosocial status. They reported high academic achievement, successful employment. They also reported some affect or mood and functioning problems, ranging from depressive symptoms to anxiety to just being extroverted. There was not a lot of description in any of these. However, post-traumatic stress and situational depression were specifically mentioned. And I can tell you, anecdotally, there do seem to be a lot of mood disorders that are more prevalent in this patient population than maybe in the general population, which would be expected. These patients have endured a lot of unpleasant medical encounters and probably unpleasant social encounters. But there's many opportunities to help these patients, as we'll talk about later. Treatment. Only 49 patients had treatment described. It was mostly craniofacial and limb, not surprisingly. Outcomes were really not discussed in many of the cases unless they were very dramatic, mostly in the negative. There were some successes that were described. Those were primarily craniofacial that were successful. Not there were some hand surgery patients that had limited success, but that's very difficult because you have to have a lot of commitment from the parents, the family, and the patient, and that's hard to achieve. Anesthesia was described in 22 patients, and those descriptions were a bit better. They did say that MH, malignant hyperthermia, which is a hypermetabolic reaction that some people can have to volatile inhalational anesthetics or depolarizing muscle relaxants, that had been hypothesized to be part of the syndrome, and the literature does not indicate that. 19 patients, they described what method of ventilation was used during general anesthesia, and 20 did report outcome data. 5 were unacceptable or treatment failures. And again, I believe those were all limb deformity cases, a hip dysplasia, and spinal surgery was included in there. So I will hand it back over to Dr. Dufresne now to talk about the discussion section of our presentation. Thank you.
So the new name of Freeman-Burian syndrome was to avoid confusion with the Sheldon-Hall syndrome. And that seems to be panning out over time. These are complex myopathic craniofacial conditions that include microsomia and what was called a whistling face appearance with pursed lips, an H or V-shaped chin soft tissue defect, and deep nasolabial folds. Freeman-Sheldon, who first described it, was independently confirmed by Burian in 1962 as a new entity. And most of these are autosomal dominant, sporadic cases. The prevalence is unknown, but considered to be extremely rare. The common deformities outside of the craniofacial issues are the limb malformations, camptodactyly, ulnar deviation, equivirus, um, abnormal spinal curvatures, chest wall deformities, and gastrointestinal problems. There's a tremendous variation in the expression from the very mild to the quite severe. Um, there's no data on life expectancy. However, there are specific significant concerns for aspiration and that leading to pneumonia in some patients. Some individuals have mouth breathing problems, dysphagia, poor tussive ability, functionally impaired intercostal muscles, which are all due to the genetic condition. The facial features are very typical. Here you see the pursed lips, the H deformity of the chin. Um, you can see on the right diagram and photograph that there are positions of the hands and fingers that are very typical with this condition. Um, the skull, as you can see here, the mandibles elongated and prognathic. The maxilla is constricted. The orbits are also misaligned and misshapen, which are very consistent with the bony problems. There's also dental issues that result from the oral hygiene that's sometimes hard to maintain because of the muscle, you know, malformations and fibrosis, which make even just opening the mouth difficult at times, and therefore the dental issues can be considerable. There's no gender or ethnic preference. There's no environmental parental factors that have been identified. The allelic variations include an embryonic myosin heavy chain MIH3 at locus 17p 13.1, which seems to impair the adenosine triphosphate binding to myosin. If the patient is noted to have any mental retardation, it's a different diagnosis, which is CLIFA HDD, which is a condition that includes congenital contractures of the limb and face, as in Freeman-Burian. There's also hypertonia, but there's developmental delays. And these are felt to be mutations in the sodium leak channel, which is a non-selective NALCN gene. The muscles are usually replaced by white fibrous tissue that acts more like a tendon than a muscle. Oftentimes this requires surgical releases in order to overcome contractures. Oftentimes physical therapy is also employed in order to try to keep muscle tone at optimal levels, although that may be ineffective in some cases. Operative findings show just a tremendous contraction and stiff muscle development, so that it's difficult for some of these patients to use their hands or legs or feet, depending upon what and how severe their condition is. The successful surgeries, the ones that are targeted to release the fibrotic tissue to try to achieve some functional goals. Surgeries on the facial skeleton often fail, though the microstomia can be improved. Some of the congenital ptosis can also be improved, and if caught at an early age, can have a more successful outcome. The new understandings for Freeman-Burian involved are usually guidelines expanded by the role of the craniofacial surgeon, who often are the individuals that deal initially with several of their surgeries. It helps with the identification of the syndrome and diagnostic criteria. There's also ability to give more counseling and education to the families. Care can be coordinated with various clinical individuals and specialties, and longitudinal psychosocial support is very helpful in overcoming some of the conditions that some of these individuals are faced to deal with. We usually try to give the families and patients as much information as we can as a craniofacial surgeon. And physiologically, most of the patients get most of their care from craniofacial surgeon. When advised for prenatal diagnostic and recommendations, if there's no identifying mental retardation, abortion of the embryo is not recommended, because oftentimes with proper care, these individuals can do very well. Molecular testing at this point is not recommended because it is not diagnostic and specific enough at this time. Clinical genetics, unless they're craniofacially specialized, are not always very helpful. So it relies on the craniofacial surgeon to make a more accurate diagnosis. And they're able to also help to at least align the complete range of rehabilitation concerns that run the gamut of orthopedics and physiatry. Problems of dysfunction of the ocular muscles has also been identified, blepharophimosis, blepharoptosis, strabismus. All are really requiring early intervention in order to preserve vision and improve, the ultimate outcome. Correction of the microstomia can be done surgically, which also improves with different nasal procedures. Reconstruction of the oral pharynx can also improve speech and dysphagia that a lot of these patients have. I think it's important that they receive oral hygiene and routine dental care and procedures, which are very difficult in patients with fibrous band formation in the oral musculatures. Teeth should be maintained as long as possible, unless there's extensive caries issues going on. More teeth are removed tend to render the mandible and maxilla more atrophic. So the teeth should be preserved to preserve all this bone mass as much as possible. Respiratory problems also should be approached rather aggressively. Allergic rhinitis and respiratory infections usually require rapid medical management, many times with a 3 to 4 day course, pseudoephedrine, guaifenesin, and antihistamines. Afebrile patients with rales, rhonchis, or crackles are treated with guaifenesin for 3 to 5 days. Febrile patients with those same symptoms often require antibiotics also for a period, because this could lead into pneumonia. Spirometry and maximal ventilation with oxygen is helpful, and helps to improve the respiratory outcome. Physiotherapy also takes in unique account the problems with the muscle contractures, and that's compounded by the progression of the abnormal spinal curvatures, again, due to reduced intrathoracic and abdominal cavity volume by the muscle contractures and the spinal curvatures. Patients are encouraged to live an active life. Operative treatment for most of the extremities is not always recommended, since they too can be typically poor. But physical therapy and orthopedic surgeons can be helpful in the correction of some of the hand developments. Optimal goals should be that to improve physiological functioning, social and mental development, and there shouldn't be much delay in these treatments. Families and patients should receive explanation of at-home hand exercises and brace use for the upper and lower extremities, although many of these also result in suboptimal outcomes if the compliance is poor. For feet resistant contractures, this is better non-operatively treated with extremity prosthesis, and should not be immediately offered amputation as a option. Preschool and school age patients should have objective intelligence and achievement testing before school in order to retrieve the appropriate academic services. Interpreting intelligence and achieving tests and sensory impairments must be considered, as they artificially reduce some scores in some patients. Irrespective of whether parents accept the psychotherapy or not, the craniofacial surgeon can be helpful to continue to help support the family and the primary source of support. As far as anesthesia goes, the avoidance of sedation and general anesthesia should be considered if the procedures are less invasive. Nerve blocks and local anesthesia can be used with reducing unnecessary risk involved with post-operative recovery in any type of general anesthetic course. If general anesthesia is required with intubation, it should be done with a fiber optic guided bronchoscope or other equipment that is used for challenging intubations. Tracheotomies should be avoided unless emergent, because they lead to their own problems down the road. Use of opioids and respiratory depressants should also be limited, since they can potentiate the risk for apnea, oversedation, or hypoventilation. Muscle rigidity should not be used as an indicator for anesthetic depth, because it's mainly due to fibrosis of the muscles, and it's unlikely that in an impending malignant hypothermia crisis is evident, but should be monitored in case temperature elevations are noted early. The fibrous tissue is not affected by the anesthesia, nor are the muscle relaxants. Endotracheal suctioning and recruitment maneuvers should be used before extubation to make sure that the patient will not go into any respiratory distress. Chest x-rays are often uninterpretable because of hypoinflation as well as distortion. Physical exam is much more reliable. So in conclusion, the improved name classification, definition, and biosocial-based clinical practice guidelines are set out for at least the minimal standards of care at this time. Hopefully, a greater awareness will lead to better improvements and understanding of the condition. More research is necessary for better outcomes. We have been writing letters to journal editors and others for publications to correct some of the incorrect and inappropriate information that's been delivered. Well, thank you very much. I hope this has been helpful and engaging. And if there's any questions, please be happy to contact us.
And we'd like to say a big hello to Charleston, South Carolina. And we're grateful for you being able to join us today.
Yeah, life invaded, and I got in a little bit late, but I got the gist of what you guys are talking about. Sorry.
We appreciate you.
It's okay, Mark. Thank you for joining. I will actually send you a whole recording once it's processed after we are done with the webinar, and you'll be able to listen from the beginning.
Well, what I'm getting out of this in a summary is nobody understands what you guys are into, and you're trying to make sure everybody does. And I don't have truly the background to truly understand what you're doing, but if Michaela thinks it's important, then I do.
Well, no one understands what you do, Mr. Novak. You're amazing.
Well, anyway, you want to see me truly clueless? Send me up a tree with a running chainsaw hung off my belt, and you'll find out what I don't know. So in this particular case, I like listening to the medical types, and I'm sorry I got in here late. Life intervened. So anyway, thank you for having me. I appreciate it.
Thank you for coming.
Thank you.
I do have a question for both of you, actually. So can you confirm that Burian and Sheldon are two different conditions? Because the way we are presenting information in our disease database is as one condition with two different.
And that's why we renamed it, because it was confusing to doctors, it was confusing to patients, to families. Freeman-Burian syndrome and Freeman-Sheldon syndrome are the same condition as we have written and I believe contributed to you.
Right.
Sheldon Hall syndrome is a separate condition. And that's why we renamed the syndrome Freeman-Sheldon to Freeman-Burian to make that distinction, because indeed the condition that Sheldon described is not the same condition that Freeman described.
So I now have three conditions that you have mentioned. So one, I just heard in this presentation, Cliff AHDD is a separate syndrome.
Yes, that is correct.
So I'm adding that. Then we have Freeman-Burian, and then also I'm gonna add then Sheldon Hall, correct?
That is correct. And we'd be happy to help you with information
Perfect.
on all of those.
Thank you so much. It's so, so helpful because, you know, we get these, you know, affected individuals come to the site, or we get emails that, you know, it's very confusing to find correct information, as you mentioned, and, you know, the reason why you did this literature review and research, and it's just very helpful to, you know, have the accurate information.
It's difficult for doctors and researchers. I cannot begin to imagine how difficult it can be for a family who does or doesn't have a background.
Right.
It brings everyone to an equal playing field. Wouldn't you agree?
Yes, I would. Yes.
Well,
It's very
yeah, thank you.
confusing when the literature has very similar sounding allocations for different conditions.
And they don't agree at all on treatment or descriptions.
Right. Yes.
Right. Well, thank you so much for explaining this one and, how you got to do this. It was very interesting too, at least for me to hear as well, even though, I'm moderating this webinar, but because I manage that disease database, it was really informative to hear this information. And Michaela, I will contact you about the other two to kind of just review, and hopefully you can give me feedback and help with the definitions and descriptions of the other ones.
Wonderful. We'd be happy to help.
Yes, thank you
Okay.
very much for allowing us
Thank
to
you.
present today.
Wendy, Mark, do you have any questions at all for?
And if I do, I will ask Michaela because we actually communicate. I'm from a completely different trade. I'm from a different part of the world. And my part of the world has the exact same communication issues that you guys do. So I might be able to help her in that point on how to try to explain stuff. And I would love to hear this whole thing from Jump Street. I just got waylaid.
Okay.
So
No
when you
problem.
get this recording prepared, I will take a copy of it, and I appreciate it because I've read everything Michaela sent me, and it's a different side of the world, and I'm really enjoying the fact that I even get to hear any of it. So thank you.
Wonderful.
sir.
Oh, thank you.
Wendy, I see you unmuted. Do you have a question?
Yeah, I will just briefly explain our situation at the moment. So she's still a baby. She's 9 months old. She has gone many non-surgical treatment. Now we can see great improvement of her hands and feet. Currently, what worries me most are her eyes. Her eyes are crossed, have slightly droopy eyelids, and widely spaced eyes. So I just want to know, are there any success stories regarding the eyes, whether it's surgical or
yes.
non-surgical treatment?
Well, there's specialists that deal with pediatric strabismus. So that would help with the eye muscle alignment. And as far as the ptosis, where the eyelids come down, it's important that those be addressed early too, because if there's any visual field cuts that persist for a long period of time, the retina doesn't develop, and the child will have either limitation of vision or loss of vision. So you probably should seek out a pediatric ophthalmologist to help deal with that.
Yeah, we are already under that care.
Okay.
Oh, that's great. Thank you.
Okay.
I'm so lucky. I'm feeling so lucky to join this meeting. Thank you so much.
Oh,
Oh, yes, I will echo that. Thank you so much for the presentation.
We are happy to be here and very thankful to have been invited.
Yeah. Yes.
All right. Thank you all, and I hope you enjoy the rest of your day.
All right.
Thank
Thank you.
Bye.